No doubt that Asherman syndrome intrauterine adhesion stays as the nightmare and the most frustrating clinical situation for gynecologists and for patients alike. We all agree it is a very poor prognosis, very difficult challenges in surgery with a potential of grave complications. The challenge starts here from the external os. You can see there is a lot of fibrosis and phimosis, a pinhole external os. It requires a very gentle and tender maneuvering of the telescope, with turning the telescope like a corkscrew, like you see here. This allowed the jet of fluid to hit the walls of the endocervical canal, clear the mucus, push out the debris, and then you get this clear view of a black hole. That's a pinhole internal os. You have to use the fluid jet as your dilator. You see now the view without proper fluid distension or not proper pressure. It's collapsed. You don't see the way. And when you increase the pressure, now you get a nice vision. So don't ask me how much fluid pressure you use. It depends. It is variable. You keep increasing the pressure until you get a good view. And then using the scissor to palpate and to dilate. Here, I'm using the jaws of the scissor. This is another $1 million tip. The jaws of the scissors not only to cut, but to dilate. Dilate to enter a space after the internal os. Unfortunately, the space looks very frustrating. Dense fibrosis, white tissues. There is no any clue of endometrium. I am sharing with you second by second the procedure, no editing. So we live together the confusion, the frustration, the fear, and feeling lost. So I created a space and pushed the telescope gently, assuming I am in the, no, this is not the uterine cavity, okay? The pattern of fibers here is not typical of endometrium. So probably I went into a wrong track. So don't get panicked, but also don't insist to go in. If I keep going in, I'm tunneling into the myometrium till perforation. So I pull back. The passage of these bubbles indicate that there is a space behind this hole, but probably it was a false passage. I don't know up till now. Let's continue and share together the challenge of zero cavity intrauterine adhesions complete Asherman. After pulling back, I increased the fluid pressure and going in again, trying to find another clue. So instead of cutting at 12 o'clock, I started to cut at 6 o'clock. Probably the uterus is retroverted, so I have to go more posterior. So when you cut in the tissues, cut by the tip of the scissor. Another $1 million tip. You should train your hand to get the tactile feedback sensation of cutting the tissues. When you cut, there is a different sensation between dense fibrous or myometrial tissues or endometrial bands. So it comes by experience, it comes by repeat. And then I push, and I feel gliding. There is a little hole. What is this? Another false track? I'm not sure. So using the scissor to palpate, to touch, and getting the feedback sensation on cutting the tissues, all these tips help you to know, now, yes, everybody is happy now. There is an endometrium, there is a cavity, there is a polyp, and the endometrium is studded by a yellowish caseous material, and that's an evidence of a possible tuberculosis. So successfully we could enter the cavity and release the adhesions. So now I'm more confident to expand more and cut into this white fibrosis on the lateral wall, expand the cavity, expand the entrance, and the patient had an amenorrhea because of the tuberculosis. It's a Cox infection and also complicated by polyp formation. So when I pull back slowly, you see now this is the internal os and Everybody can appreciate my mistake cutting at 12 o'clock, which was actually tunneling into the anterior wall of the, but I didn't follow on. It's all in the tactile sensation. So the case has really nice cavity at the end of the procedure, and this is the histography before and after. My dear friends, listen to me, never give up. That's Osama Shawki from Cairo, Egypt.